Okay, in that case, it would be my pleasure and honor to introduce Dr. Unnikrishnan. Dr. Unnikrishnan is an endocrinologist and CEO of Chalaram Diabetes Institute based out in Pune, and which is an IDF certified Center for Education Excellence in Diabetes Care. He heads the clinical care, clinical research, education, and also oversees philanthropic rural diabetes care program at the institute. He has published several studies and has more than 160 publications in index journals to his credit. And one of the few which I would like to mention specifically over here is that he has published the largest multicentric study of subjects with pancreatitis and pancreatic diabetes worldwide, in addition to his other publications. He's also the former editor-in-chief and founder editor of Journal of Thyroid Research and Practice, and is executive editor of the Indian Journal of Endocrinology and Metabolism. He has received several awards to his credit. Some to mention here are Subhash Mukherjee Oration Award of the Endocrine Society of India, and Srivastava Award of RSHDI for his contribution to diabetes in India. He's also received a Jacob Memorial Prize for the Best Patient Care awarded by Christian Medical College in 1998, and Fellowship Award of the RSSD in 2017, and Dr. Sam G.P. Moses Oration Award by Diabetes Association of India in 2018. Dr. H.E. Unnikrishnan will be talking on keynotes from the UK CPRD Clinical Practice Research Data Link. Over to you, sir.
Thank you, and it's a pleasure being here. I thank Dr. Banshi Saab for the invitation, and Dr. Tejas Kamath for the kind introduction. It is a pleasure to virtually meet Dr. Banshi Sabu and of course Dr. Tejas Kamath, whom I remember meeting in Goa many years back at a CME. So on that note, let me talk about my presentation, which is going to be a very short presentation. I'm going to talk about some interpretations of the UK CPRD Clinical Practice Research Data Link. Now, just a few words up front. This is a real world study on gliclazide, and it looks derived from a database from the United Kingdom. And my task is to introduce you to the key outcomes of the study and to also discuss what are the implications. I hope I'm visible and audible. Yes.
Yes, sir. Yes, sir.
So this is a study which is a real-world comparative effectiveness study of gliclazide versus sitagliptin as a second-line therapy. We know that after lifestyle modification, the American Diabetes Association recommends metformin. Now, when metformin doesn't work, then you add on a second drug. Now, here is a study which looked at what the second drug could be. In clinical practice, it is often sulfonylurea, it's otherwise DPP-4, it's otherwise SGLT2. But if you are looking at, say, a sulfonylurea like gliclazide modified release versus sitagliptin as an add-on therapy, what does this particular database reveal? And this is a recent publication, and it is from groups in both UK and France, and notably Dr. Kamlesh Kunti and Dr. Melanie Davis from the University of Leicester and the Leicester Diabetes Center, and it is a recent publication. So again, once again, the aim is to compare the effectiveness and safety of gliclazide modified release versus sitagliptin, and the primary outcome is the time taken to reach a HbA1c of less than 7%. When I present, it will be apparent that in one group, they looked at the proportion of people at each time reaching A1C below 7% and then comparing the two groups. The second is, of course, using an HbA1c cutoff of 6.5. And of course, there are several other important outcomes such as hypoglycemia, durability, and persistence. So this is how this study was conducted. They used a wide register or a database, and after a baseline period, an index date was 1st of January 2010, and the last date taken was 21st of October 2019. They took new users of gliclazide and sitagliptin, and they looked at A1C assessment, durability, persistence, and hypoglycemia. The observation period was 9 years. The main inclusion criteria was type 2 diabetes in adults already on metformin, HbA1c more than 7%, and 12 months of historical data prior to the index date. The main exclusion criteria of this publication was standard, type 1 diabetes, gestational diabetes, neonatal, etc. So this database looked at 45,534 subjects with the inclusion criteria, excluded initially 10,000 by study design, and another 3,393 were excluded because of missing data. Finally, 1,207 subjects in the glycoside group were included, and another number 5,479 from sitagliptin. Now they did what is called a propensity matching, comparing these two for all the propensities, and then they came up with 993 on glycoside and 993 on sitagliptin. So I'm not an expert on propensity matching, but this particular propensity matching score was used to match patients who initiated glycoside versus who initiated sitagliptin, who did not have any missing data. And what they did was to match these patients as closely as possible without actually matching for the drug. For example, if you're comparing glycoside and sitagliptin, you can't match for that because these two are same. Except for everything else, they attempted to match using this matching score. So when you look at the baseline characteristics, they were pretty much similar. You can see the gender distribution, the A1C 8.5, 8.6, the diabetes duration 4.5. This very close comparison of characteristics between the glycoside group and the sitagliptin group was because of the matching that was done. And you can see very closely most of the inclusion criteria, most of the baseline characteristics matched the history of hypoglycemia before starting therapy, chronic coronary disease syndrome, blood pressure, dyslipidemia. So well matched two groups. So here is the result of the primary outcome. As I said, as this graph shows, in the y-axis you have the duration in years, and in the x-axis you have the probability that a patient would reach an HbA1c below 7%. You can see there is a rapid separation of curves as early as within, say, 3 months. And what you will also see is that there is a higher chance that higher probability of reaching an A1C below 7% in the glycoside group versus sitagliptin group of up to 35%. So once the curves had separated, people on glycoside had a higher chance of reaching an A1C below 7% when compared to sitagliptin, and this was sustained. If you look at glycoside versus sitagliptin based on ethnicity, based on baseline chronic kidney disease, based on baseline cardiovascular disease, you will see that the p-value of interaction was not significant. In other words, the results were maintained despite the presence or absence of kidney disease, regardless of the ethnicity, whether it's Southeast Asian or European, regardless of the presence or absence of cardiovascular disease, and similar with age. So just to show that these characteristics did not make a difference, except for maybe cardiovascular disease, where the p-value could be considered borderline in glycoside group, but otherwise nothing was affected. If you look at different patient subgroups, different diabetes durations, it was consistent. If you look at an A1C below 6.5%, again, 50% more people on glycoside were likely to reach a A1C below 6.5% compared to sitagliptin. Durability was similar. We've always been told that glycoside is a drug which causes beta cell failure. Glimepiride causes beta cell failure. Glycoside causes beta cell failure. Sulfonylureas cause beta cell apoptosis and amyloid deposition, and therefore they are not durable. But here durability and persistence were both similar. What is durability? Durability is the treatment duration till the metformin plus glycoside combination was stopped, switched, or a new drug added on. And if you look at persistence, it also corresponds to treatment duration, regardless of add-on of another anti-diabetic drug. So whether the anti-diabetic is added on or not added on, in both ways, durability and persistence were similar. So very surprising, and this is in my mind the most surprising result, that glycoside had only a few more hypoglycemia events compared to sitagliptin. Very marginal if you look at this large number. So overall, there were 20 hypoglycemia events, 15 in glycoside, 8 in sitagliptin. Severe hypoglycemia was 4 was 1. Now, how do I interpret this slide? Well, I don't think the question is glycoside better than sitagliptin? Sitagliptin doesn't produce much hypoglycemia, and we know that all sulfonylureas, glimepiride, glycoside, all produce hypoglycemia. This is just because of, remember, a United Kingdom, European population, which is much more aware, take care of their events. This may not play out in a multinational study or multi-center study involving, say, a country like India. So I agree that glycoside caused more hypoglycemia, and that was shown in the study. Maybe the low number of events was overall because of a more enlightened, aware European population. Well, some reassuring data nevertheless about glycoside here. So there are a lot of advantages and limitations of this study. This study is a real world evidence. It cannot be compared to a randomized control trial like UKPDs or something like that. So as randomized trial, comparing all combinations of type 2 diabetes medications are not feasible. This is a cost-effective tool that can be used to compare effectiveness, or rather called comparative effectiveness study in electronic health record databases. Now, another limitation is the background information on metformin dose was really not well documented, and the dosage of the second index treatment was not really there in every patient. Weight and body mass index were not recorded over time. Hypoglycemic events were based on those recorded in clinical practice records and events related to hospitalization. For example, if the patient had a major hypoglycemia at home and family took care of it, that wouldn't reflect in this register, whereas it would reflect in a clinical trial because at the next visit, the specific question would be asked. But nevertheless, to our knowledge, this was the first study directly comparing real-world evidence of glycoside modified release versus sitagliptin as second line. This shows that glycoside modified release does have an important role in clinical practice, and further research on other safety outcomes and patient weight are needed to elucidate the entire risk profile of this population. So what are the clinical implications of this? Does this real-world data complement the evidence of randomized controlled trials? So this is the evidence from randomized controlled trials, the GLIDE study, which compared glimepiride and glycoside head-on. This was a randomized double-blind study of 845 patients with type 2 diabetes for 6 months. Glycoside, when added on to metformin, was slightly better than glimepiride added on to metformin in terms of hypoglycemia. And if we were to look at, in terms of HbA1c, and if we were to look at hypoglycemia, there was a 50% reduction in hypoglycemia in glycoside compared to glimepiride. Does this reflect what I see in my clinical practice? I agree that glycoside and glimepiride cause more hypoglycemia when compared to, say, sitagliptin or linagliptin. But if you compare with glimepiride, I think glycoside modified release is smoother with less hypoglycemia. So you can see very similar A1C reduction. In fact, glycoside a little more A1C reduction, but with much less hypoglycemia in the glycoside group in an RCD setting. Now, this is a study which was the landmark trial. Really, there were two groups, one with intensive therapy and conventional therapy, and the well-known advanced study. And important to note that this study was not a glycoside randomized controlled trial, but in the intensive group, they used glycoside-based intensive therapy. What the study showed is that a glycoside-based intensive therapy showed a better efficacy, but overall, the intensive group, the A1C came down to 6.5, whereas the control group, it came down only to 7.3. And that is expected because in the intensive group, you're going for intensive control. So no surprises there. This is not because of gliclazide or insulin. Intensive arm reached a better A1C control of 6.5%. But what the study found is that the gliclazide-based intensive regimen resulted in a significant 10% reduction in primary endpoint of major adverse cardiovascular events or microvascular events of p-value of 0.01, mainly driven by a reduction in nephropathy. So friends, intensive therapy obviously will reduce A1C, but a gliclazide-based intensive therapy by reducing nephropathy improved both microvascular and macrovascular composite events. So this was the old intensive arm of the advanced study, and the future post-trial follow-up of the advanced on study with a total follow-up of 9.9 years, showing you that the gliclazide group resulted in a 46% lowering of end-stage kidney disease. So if you see in this group here, on the x-axis, you have the follow-up duration in years. In the y-axis, you have the cumulative incidence of end-stage kidney disease. What the study showed is that with each year, you can see in the standard group, there was an increase in end-stage kidney disease. In the gliclazide-based intensive treatment group also, there was an increase in end-stage kidney disease, but it seems to plateau off at about 10 years. There is a 46% lowering in end-stage kidney disease. So we are told that sulfonylureas cause beta cell failure, they cause hypoglycemia, they increase CV risk, they may not protect the kidneys, and that we should use new and expensive agents. Well, here is the UK CPRD database, which is a well-designed, unique real-world data which complements the real-world evidence in RCT. So sulfonylureas are inexpensive drugs. We have used them for years. The risks and benefits are well understood. Hypoglycemia is a problem, but if you see the HbA1c lowering, that's much better than DPP-4 inhibitors. And in India, we have used them for years. And let us look at India as a country where cost is an important consideration for a disease like diabetes, which is really 74 million people with diabetes in India. If you look at the old sulfonylurea versus the modern sulfonylureas like gliclazide, the modern ones have shown good efficacy and durability. If you see the UK CPRD study, there is evidence that gliclazide modified release is an effective glucose-lowering drug with similar rates of hypoglycemia, durability, and persistence in treatment. Well, we know the results of the Carolina study, which showed that glimepiride showed similar cardiovascular neutrality as compared to linagliptin. We now have the UK CPRD database, which showed that gliclazide, though it's not an RCT like Carolina, this real-world study showed gliclazide has a better chance of your patient reaching an A1C below 7 or 6.5 also compared to sitagliptin. I think there is, with these two studies, there is good, robust evidence that sulfonylureas are economical, effective drugs with strong lowering of A1C. Yes, you might have to watch for hypoglycemia, but here gliclazide may have an edge. And finally, in the advanced on study, which was an intensive glucose control study aided with the use of gliclazide MR, I think there is evidence that these drugs, by reducing end-stage kidney disease, reducing the occurrence of nephropathy, can actually improve both micro and macrovascular disease composite by about 10%. Well, it has been an absolute pleasure discussing this topic. I thank Dr. Banshi Sabu, the entire DICON team, Dr. Jitendra, my friend Dr. Tejas Kamath, all for giving me this opportunity, and have a great day. I'll be around for questions if you need to ask me.